I'm going to talk to you about below the ankle revascularization, but I thought, why not give you something a little bit more challenging, which we see in our daily life, day to day. And the reason I did that, because again, I want to reiterate my point earlier. We need you. Our patients need you. And without you getting back into endovascular revascularization, the epidemic of CLTI right now is on the rise. The amputation rate is significantly on the rise. Is actually more than 4% year after year, where we're supposed to be lowering it by 2030. But I don't think we're going to get there. I think Dr. Dippo is going to be talking about that later. So below the ankle endovascular revascularization, it's definitely something that broadens your horizon. And if you follow the guidelines, right, you can't just treat the below the ankle. You have to have an inline flow to the foot. So you have to treat everything from the common femoral artery, assuming the iliacs are intact, all the way down to the foot. This can be done by yourself. If you're an interventional cardiologist, you have to work with your interventional radiologist, and you have to work with the vascular surgeons. And none of us is alone in this. All of us have to work together. Regardless of what happens with the New York Times article, still I believe in my heart that the subspecialty or multidisciplinary approach is the way to go. That's the best thing for the patient. So angiogram-directed therapy here is the target of this discussion. This patient had a popliteal to distal PTA venous bypass. That was failed 6 weeks later. There are some good bypasses that actually last longer, but this one failed. Now the patient has two non-healing wounds, and the original lateral plantar ischemic wound that the bypass was done for is becoming worse, and anastomosis site also became infected. And the endovascular revascularization here, although failed, and the next option for the vascular surgeon to the patient is either amputation or discuss it with someone that can do endovascular revascularization. And luckily, this patient was sent to me by the vascular surgeon, and I appreciate it because the patient wasn't septic yet. Cellulitis was there in 2 different wounds, but the patient wasn't septic. So here's the angiogram. The first time you look at it, you wonder, okay, so where do I start? What do I do? Makes sense, right? Lateral plantar wound, so you want to open the posterior artery, and also the anastomosis site is infected, so you want to get the posterior artery open as well to have collaterals to the wound in the area. Looking at the angiogram here, you can tell that there is no significant flow below the ankle, and that needs to be treated. And you can just go directly focusing on that, or you can just take a little longer here, look and see what else do you need to do, and what else was missing, and why did the graft failed. And earlier, Dr. Amin was talking about venous disease, outflow. Same thing here. The inflow is not complete. So let's see if we can look at the inflow and look at the outflow and create a good inline flow from the groin to the foot to have a successful revascularization for this patient. So actually this patient can heal. And this is a great case to pick for you to see. As you go on with your career, you're going to face some obstacles. And when you face the obstacles, make them be way for you to learn how to overcome these obstacles, so the next time you face them, you can have a solution for them. In this case here, we tried to get a good visualization of the PT. We couldn't get a good one, so we get a retrograde micropuncture sheath in it, and we took a look. And by looking at the second image, you can tell the CTO cap here, based on the CTOP classification, that's going to be a nightmare to cross from above. And so we thought we'll do integrate retrograde for that one. So definitely you can see here there's an integrate retrograde attempted, but notice what happened here in the last 2 pictures. The one wire went one direction, the other wire stopped at one point. When that happens, the next thing you need to do is figure out why. And the best answer is you look for clips or sutures, or you do IVUS. All of them can help. When you see this image, the last image on your right over there, how the artery goes down and clamps onto the IVUS, this artery was clipped, pretty much transected. And the anastomosis itself, that could be done intentionally sometimes, but sometimes if the anastomosis is not done properly, this artery collapses, and as the tissue heals, it actually transects the artery as well. The vascular surgeon and I discussed it. He felt maybe some of the sutures led to this transection of this artery and no longer viable to open it. So now we can open the PT. So what would be the next option for this patient? To give this patient what he or she needs to heal a wound at obviously the PT circulation and the lateral plantar. And the PT is not there. So what are the options? Let's look into it. Well, the first thing you think about, well, if I open the PT and see if there's enough flow in the PT that creates enough collaterals that perfuse the tissue around the anastomosis site, which is non-healing wound that is infected, then that should be sufficient, right? But the images here shows, the second image shows that there is not enough collaterals to fill and they're not perfusing the skin. So that concept here is not going to be good. So we have to find an alternative way. Well, alternative ways are going to be making sure the inflow and the SFA popliteal are good and the AT is open, the loop is intact, and now not only do we have to open the below the ankle vessels, we have to open them very well, but also we have to open the inflow into these vessels. So you can see here we elected to do DP access below the dorsal spheres, and then used antegrade retrograde balloon angioplasty because we could not advance any catheters through this heavily calcified AT. So the surgery was appropriate, distal PT bypass. Unfortunately, it didn't work in this case. In some cases, it works. But this artery, the AT, is obliterated, it's difficult, and you can use coronary low-profile balloons to create a lumen to cross. If you notice in the last picture over there, the wires from above and below, they're not meeting where they're supposed to meet. So you use what technique we talked about earlier. You bring an 035 catheter and you rotate it until both antegrade and retrograde wires or catheters meet in the center of the vessel. And once you get there, then you can treat and get the results that you want. Using a 035 catheter, bringing it down and then rotating it into the really highly calcified and completely obliterated lumen with high plaque burden, you have to reduce that burden somehow. You can balloon it if you believe in balloons. You can use lithotripsy if you believe in that. You can use a atherectomy. Anyway, you've got to alter the plaque burden. And in here, we use multiple recurrent balloon angioplasties. And then after that, we tried, after we ballooned it, to see if we can connect the antegrade, retrograde wires and catheters together to do the Flossen technique and then deliver therapy. And this is not something that you can do in half an hour. You're going to take your time to do it because the alternative for this patient, again, is below the ankle, below the knee amputation. So the target here is to treat below the ankle to save the leg. But to treat the below the ankle successfully, you have to treat the route to it, to get the inline flow based on the guidelines. So we're still following the guidelines. After trying to get that open, we decided to get the inflow in the popliteal, especially at the site of the anastomosis where the graft came off. We found that there's a high-grade stenosis there and granulation in some tissue. And IVUS always tells you what you need to know. If you're in doubt of why the catheters and wires are not moving very well, IVUS. This IVUS here showed us that there's significant burden and obstructive elastocalcinosis disease present in the vessel, so we have to debulk this somehow. So you can choose your method of debulking that you're comfortable with, any form of atherectomy you're comfortable with, and when you do that, look at the balloons afterward, what happened. The balloons actually start to go down, inflate them, and you have a nice 1-to-1 ratio of the balloon to the vessel, and now you know that you can continue your work toward the below the ankle, and now you can reassure yourself that you're going to have a good below the ankle high perfusion pressure to have retrograde flow into the PT, into the infected site. So in a setting, to ensure sufficient below the ankle revascularization, the first step is to ensure the infrainguinal sufficient flow. So we looked for that, we treated it. And the second step is to do below the ankle revascularization to restore BTK sufficient flow. I mean, they have to stop for a second and think about it. What do you mean by having sufficient below the knee flow by fixing the below the ankle flow. The reason you have to do that because if your flow below the ankle is not good, the flow below the knee is not going to be good. So keep that in mind. And this is where the access was in the dorsalis pedis, which sort of moving the blood out of the way as we move the balloon to obtain hemostasis. And you can use integrate PT access in this setting if you need to, or pedal loop reconstruction. Now, the best way to do this is have a catheter down, do an epicranial with an oblique view, or ipsilateral epicranial oblique view of the dorsalis pedis, and then you follow the wire and you cross the pedal loop to where you want it, and then you use the IVUS obviously, and then measure the vessel. Believe it or not, most of the time the lateral plantar artery and the procedural artery, the range diameter of them is 2.5 to 3 millimeter. So we treated those with these size balloons, and atherectomy was performed as well. And then we knew that there's a bunch of lesions in the higher up, so we used up to 7 millimeter balloon and asked him the SFA come from the artery junction. We treated the pulpiteal SFA, and we treated the pedal loop. So although this is about below the ankle revascularization, but if you don't have a good inflow, the below the ankle revascularization is not going to help. If you don't have a good outflow, the below the ankle revascularization is not going to help. And this patient needs all three of them to have a good limb salvage procedure. Now, take a look at the flow now and pay attention the most at the brisk flow that you see in SFA popliteal now that you didn't see that before. Now, that is not brisk because we opened it. It's brisk because now there's a good outflow and there's a good venous return if you actually do venous phase. And most critical part is the below the ankle revascularization. You do multiple shots to look for what? You want to look for comparative flow. You don't want to see complete pedal loop filling from an injection, from a selective injection, whether it's the PT or the AT or the DP. You want to see sort of comparative flow. When you see comparative flow like you do in the picture before the last, that's a good sign. There's comparative flow now. Now you know that the lesions in the lateral plantar is going to be very well perfused. Now you know the anastomosis site is going to be very well perfused. So that's a complete revascularization of below the ankle, although it required inline flow and therapy of the above the knee disease, below the knee disease, and below the ankle disease. And this patient went back to the wound clinic, and within 6 weeks or so, the anastomosis site healed, and actually lateral plantar wound took a little longer though, but it healed, and the amputation was prevented. And that is actually a great example of multidisciplinary team working together. And still, that is the way to go, is multidisciplinary team. So I encourage you again to go back after endovascular revascularization, especially for CLTI, and don't let anyone intimidate your skills and your ambitions. I wish you the best.